Neat. So this is Harm Reduction 101 training. I'm Juliet Ledesma. I'm the interim program admin for the Outreach and Connection team.
And I'm Alexis Meacham. I'm an outreach case coordinator with the Outreach and Connection team.
Just a little bit about us. I have background in harm reduction work from my time working at the Cambridge Needle Exchange for about 2 years, from 2018 to 2020. Spent about 7 months with Bivent Health, but trained as a volunteer at Harm Reduction Action Center, where I met Alexis.
Yeah, and so I've been doing harm reduction work in Denver since about 2016. I worked at the Harm Reduction Action Center for several years and have just been doing the work out here, which is where I met Jolie whenever she started volunteering with us. And then we both ended up working at the city at the same time and were able to come together and make this Harm Reduction 101 training.
We're going to get through a lot of topics. We're going to go through a lot, including overdose prevention. We'll go over some goals initially. Number one, just remember to take care of yourselves. If something comes up or brings things up and you just need to take a step away or take a breath, do whatever you need to do. There will be a lot of content. Ideally, we'll have time for questions after. We'll do our best to check in during the actual presentation. But yeah, so let's go ahead. So some goals for this presentation. One of the goals is to provide context as to why harm reduction exists as an approach. Also to provide basic knowledge of materials and substances used by people who use drugs. This acronym will also be PWID, specifically for people who inject drugs, that we may come across in our everyday lives and the day-to-day work that we do. And it's also to provide information about naloxone and overdose prevention.
So we're going to say, what is harm reduction? So the National Harm Reduction Coalition defines harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. We use harm reduction all the time in our everyday life. We use seatbelts, that's harm reduction for when we're driving a car, helmets when we're riding a bike, or if we're snowboarding, sunscreen, condoms, cigarette filters, you name it, anything that we can use to reduce the risk associated with a certain activity, that's harm reduction. So we're going to talk about the principles of harm reduction. So the first one accepts for better or worse that licit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. The second principle understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence and acknowledges that some ways of using drugs are clearly safer than others. The third principle establishes quality of individual and community life and well-being, not necessarily cessation of all drug use as a criteria for successful interventions and policies. Number 4 calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs in the communities in which they live in order to assist them in reducing attendant harm. Number 5 ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. Number 6 affirms people who use drugs as themselves as the primary agents of reducing the harms of their drug use and seek to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. Number 7 recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. And then number 8, the harm reduction does not attempt to minimize or ignore the real and tragic harm and danger that can be associated with illicit drug use.
Okay. I'm seeing in the chat someone mentioned that they couldn't hear us talking. Are there people having difficulty hearing us? No?
Can you all hear us okay? Okay.
Okay, thank you.
Thank
Great. Cool. So a little bit of context, we're going to go into a bit of the war on drugs. And so some of us are familiar with this. The war on drugs was a phrase used by President Nixon to describe the United States drug policy in the 1970s. Ronald Reagan furthered that drug policy with the focus on prohibition, which led to the boom of incarceration rates of specifically Black and brown folks in the 1980s. So the biggest thing to come out of the war on drugs was the Anti-Drug Abuse Act of 1986. So this increased penalties for drug possession, created mandatory minimum sentences for drug-related offenses. So namely around marijuana, crack, and crack cocaine. And so the biggest part of this clause is the 100-to-1 disparity for crimes related to crack versus powder cocaine. So specifically under this law, people would be convicted with possession with intent to distribute with the mandatory 5-year sentence for quantities of 500 or more grams of powder cocaine. That's a lot of cocaine. It's very expensive. That's a very expensive amount of cocaine. The same sentence, however, would be applied with the conviction of possession with intent to distribute with the 5-year sentence for only 5 grams of crack cocaine. And so this is the biggest disparity that we see. So it's both the influx of cocaine into our country during the 80s. That kind of gets touched on in the Iran-Contra affair, which allowed that influx to happen. And then from this, crack cocaine was more widely available and able to be produced. It was a lot cheaper and a lot more accessible. So this disproportionately targeted communities that could afford it and communities that it boomed, and these were mainly Black and brown communities. So the important thing to know about this tidbit of history is that this sets the precedent for all drug policing in our country going forward. And it's what led to tripling our incarceration rate, right? It just keeps getting cracked down on. And so this is one of the things that we need to be mindful of when we're thinking about all of our prohibitive drug policies and what that does and who it actually impacts in our society, especially when doing this work. So some things to know. Harm reduction does not necessitate nor require a path to treatment or recovery. Some folks may never be in recovery, and that's okay. Applying this approach means meeting people where they're at. And so we enable the autonomy of an individual when we respect their priorities and decisions around their own individual choices. We must keep dismantling racism inherent in drug policies at the forefront of this work to ensure the practice of harm reduction remains effective. This work is work that breaks down oppressive power dynamics, or at least aims to, in the name of community care, solidarity, and keeping each other safe. And lastly, let's all strive to keep looking at substance use disorder as a systemic issue and not a personal one. Substances aren't bad or good. Situations are usually what's harmful or helpful. Situations are usually dictated by one's environment, and systemic issues such as injustice, poverty, racism, classism, etc., strongly dictate one's environment. So in this work, in our day-to-day lives, wherever you are, let's always try to strive and reframe personal barriers to systemic ones. Like what on the outside is affecting individuals, right? What is in the way of their own success? And we want to support that.
So now we're going to talk about substance use and person-first language. This is something that is really applicable in the day-to-day work that we all do. You know, having person-first language whenever we're talking about people who use drugs can be the difference between somebody really talking to you about their substance use or, you know, talking about ways to be safer in their substance use, which is what we're always looking for. It helps us meet people where they're at. So yeah, let's dive into it. You can see on the infographic, it goes into a little bit more detail. We'll send the slides out too, so if you want, you can look at those. So person who uses drugs or PWID, person who injects drugs or PWID, this can be used to describe anyone who uses substances or injects drugs. We say substance use disorder instead of addiction because addiction is an incredibly stigmatizing term and it's frankly outdated. So instead, you can say person with a substance use disorder and saying someone has an addiction or is an addict. Use sterile and used. These words are typically used when we're discussing equipment, so syringes, cottons, cookers, pipes, etc. You want to avoid using the terms clean and dirty as they perpetuate the stigma that drugs and people who use drugs are dirty. And you also just want to stay away from the clean, dirty dichotomy when you're talking about people in general, but especially when you're referring to people who are in recovery. So instead of saying they're clean or they're getting clean, you can say this is a person who is in recovery. Instead of saying dirty, this is a person who uses drugs. Reinitiating use, instead of saying relapse when talking about someone who was in recovery but is now using again, you can say they have reinitiated use. Relapse is steeped in stigma and sends a message that there's a moral failing if someone chooses to use substances again. And like Jolie said, substances have a morally neutral meaning, so they're neither good nor bad. You want to try to not use words like addiction, substance misuse, substance abuse, or hard or soft drugs. Saying substance misuse or substance abuse implies a willful misconduct on someone's part about using drugs, and that's just not the case. Hard and soft drugs, instead of saying hard or soft, you can say licit or illicit drugs. Or you can say highly stigmatized drugs as well. And then you never want to use words like junkie, crackhead, addict, shooting gallery, or tweaker, as they're all very stigmatizing. And then at the bottom, we have a little caveat that says that folks with lived experiences can use whatever terminology they want to describe themselves and their own experiences. So this isn't to tone police people who have lived experience who may want to refer to themselves in a specific way. This is about how we professionally and as harm reductionists can refer to people in the most respectful manner.
We're going to dive into some substances and materials right quick, but I am curious just to see if anyone at this point has any questions so far.
Yeah, David.
Yeah, David.
Yeah, so this is going to seem like a pretty self-explanatory question, but if you have lived experience using drugs, would you say that it's better to err on the side of professionalism, or is there bridge building that can be done with the people who are actively in use using that sort of language?
I would say that's totally up to you. If you feel comfortable in that space, diving into that, self-identifying a certain way, then that's totally up for you to decide and it's appropriate. If you don't feel that way, then don't do that. But I would say it's just up to you and like how you feel it may or may not help in the situation.
Yeah, going off of that, I think same deal. Oh my God, I had a thought and now it's completely out of my brain. I'm so sorry. I agree.
So yeah, you can choose for yourself.
Oh, what I was gonna say was, just like any disclosure, right? It could be substance use, it could be any sort of behavioral or mental health issues that you live with, right? Like it can be any of those things. So anything that you would otherwise disclose or not disclose to try to build that bridge. I think there's that difference between disclosure's connection and like vulnerability with someone is connection, but that isn't in a way that's putting anything or responsibility on them, right? Like I think, you are all, you're all professionals in the way that you can guide that. And so I think it's the same exact sort of concept.
Yeah, and then we have a question in the chat. If someone with lived experience uses one of those terms, should you use whatever term they self-describe as? No, I would say that if someone with lived experience uses a term that we've mentioned, like not using or erring on the side of not using, you should not describe them the way that they describe themselves. That's only for them to use. You want to use person first language to show like respect and care for this person. But that's a great question.
It's very common for marginalized communities to have terms that they take back, that they reclaim and use with each other, that other people are not allowed to use. And so it's the same thing.
Good questions, y'all.
Anything else before we continue? Oh, neat. So some substances and materials. So these are things that we'll come across in our everyday life, in the work we do, et cetera. Things that get used here and a lot of other places as well. So the first is methamphetamine. Out here, it's mainly called clear, can also be called glass, crystal, tina, scante can be one. And so the materials typically used, you can inject methamphetamine, and we'll get to injection materials in a little bit. But mainly it's smoked. And so what you'll use for smoking methamphetamine is a bubble pipe. And there's pictures on the next slide of all of these things, so we'll get to see little examples. But it's a glass straight pipe with a big bubble on the end, and so you'd stick your crystal meth in there and use a torch lighter to go ahead and burn it. Some folks sell these pipes, or like head shops will sell these pipes as oil burners. Out in LA, we call them pookies. I thought that was a whole West Coast thing, because when I was over in the Northeast, I called them pookies and no one knew what I was talking about. And then when I came here, I was like, cool, I can say pookie and everyone will know what I'm talking about. And nobody knew what I was talking about. And so terms can be regionally specific for both substances and materials or works that are used. So that's something to keep in mind if you don't understand what someone's talking about, or if you hear a term for something, you may have heard something else, just something to keep in mind. So cocaine and crack, cocaine can be called like blow, snow, and then crack cocaine, typically just crack or rock. There was like a bit of it I've heard back in the 90s called pink champagne that made like a quick comeback in the early 2000s, but that was really in the Northeast. So I don't know if that really happened out here. But you can inject either of these. The materials will be the same for injection. We'll get into when we get into heroin. But for smoking, it's a straight pipe, also known as a stem, or straight shooter, and it's just a straight glass pipe, and you'll use copper scrubber, chorboy, rolled up into a little bit to stuff in the end to act as a screen, to be able to hold your crack while you flick it with a lighter to smoke it. And with cocaine, for the most part, it's insufflation, so snorting. You'll use a table, mirror, card or razor blade to chop it up into a line or whatever, and then use a straw with a cut end or something else to snort that. So then we get into heroin. So out here and typically in the West, it's all black tar. And so where meth is typically called clear, black tar heroin is called black. It can also be called dope, tar, smack, China white, which is a popular name for like powder heroin that is white in color. It can also be called down in some areas. But typically, at least black tar heroin has to be injected. And so injection materials include alcohol pads so that you can swab the injection site, make it free of bacteria, or at least make it disinfect it a little bit. A cooker, which is where you'll put in the black tar as well as some sterile water or saline to dissolve it. You'll cook this, so after you mash up or mix your solution, you'll cook it or flick a lighter underneath it, and it should bubble for 5 to 10 seconds, and this will kill off bacteria, certain viruses, etc., making it a sterile shot, or not a sterile shot, but a shot that is freer of more bacteria and other things. And that cotton, which you'll put in the solution, and this acts as your filter, so it'll absorb some of it. You'll take your syringe, press the tip of it to the cotton, and draw up through that. So what this does, it's going to filter out anything else in the cut that didn't break down with heat or in the water or saline, and getting unwanted solids and anything else extra that might be in your shot or your product, so it doesn't go inside your body. You'll use a tourniquet to tie around your arm or whatever part of your body you're going to inject to make your veins pop, to make them more accessible. Yeah, and so the conglomerate of injection materials that you may use can be referred to as works or gear. And then we'll get into fentanyl. This can also be called just fetty. Blues are the pressed perk 30s that I think we've seen a lot of recently over the last few years. It can also be called down. There's also trank and trank dope. So trank and trank dope is historically common in Philadelphia. So this refers to fentanyl with tranquilizers such as xylazine. So black tar heroin or other powder heroin in the past, typically you could do a shot, snort it, what have you, and you could be high for quite a few hours and wouldn't need to re-up or reuse if you were trying to use more. Fentanyl is very fast acting. It wears off super quick. And so tranq dope is fentanyl mixed with tranquilizers to mimic the length of time you would be high from older heroin. The length of time something keeps you high for is known as legs. And so old heroin had legs, fentanyl does not. And so the tranq dope is trying to recreate that. But yeah, it's been common in Philadelphia, is hitting more of the Northeast. There has been some cases of fentanyl with xylazine out here. In Denver, it is slowly spreading and making its way west. But yeah, materials for injecting fentanyl are the same as above. Pretty much anything that you were injecting of any of these substances, you would ideally use all of the materials listed above. For the Press Perk 30s, we're mostly seeing people smoke them. So this needs foils, straws, a lighter. Basically, you'd have a piece of, you take a piece of foil and fold it, and you would put a piece or all of the blue on the foil, and you'd lick underneath it with a flame until it started to smoke. And then anything like a straw or like a body of a pen, anything that you can use to inhale that smoke. And this is called chasing. And so this is typically how folks smoke blues.
Yeah. And now we're going to briefly touch on the newer fentanyl bill that was introduced last year in the state legislature. So it's called the Fentanyl Accountability Act. And so basically, what this has done is undo some drug policy that had been done a couple years ago, which was to make misdemeanors out of small personal possessions for folks. So this made any fentanyl compound possession of 1 to 4 grams a level 4 felony, which is punishable of 180 days in jail and 2 years probation. And then any subsequent arrest for any fentanyl compound of 1 to 4 grams could be up to 364 days in jail. We bring this up just to kind of talk about drug policy and to give you a critical lens of looking at drug policy. So this bill came into fruition because of the response of the uptick in fentanyl use that we're seeing across the United States and in Denver specifically. I can surmise that it was made as, some type of action to try to curb fentanyl use, but really what this is going to do is cause a lot of people to be incarcerated more, to have more legal repercussions to substance use. If stigma, shame, and incarceration worked, we would have wrapped this up years ago, but all that it's done is driven drug use underground where people are dying of preventable overdose deaths, putting us into the worst overdose crisis we've ever seen before, and where people are dying of preventable diseases as well. So we want to be able to talk about drug policy and think about who is this benefiting and what kind of harm will this do to people who are using drugs. And so what we can see with the new fentanyl bill is that a lot of people are getting felonies now instead of misdemeanors for possession. And when I say fentanyl compound, that can mean that it could be I bought heroin or what I thought was heroin from somebody, and there's just a little bit of fentanyl in it. It can be any trace amount of fentanyl, and that is considered a fentanyl compound. And so it's also important that we get into the nitty-gritty details of stuff like that too, because of how it can be misleading for some people, and it can be misleading for people who use drugs.
We'll touch on this a bit later too, but those traces of fentanyl constituting compound or mixture, we'll get into contamination and what that looks like, because we don't actually know at what point in drug distribution supply from top to bottom, that contamination happens, right? So we hear a lot specifically around folks who might use cocaine or prescription drugs or something that maybe has a trace of fentanyl who wouldn't typically be thought of as a common drug user, intravenous drug user, right? And with that stigma as well, they could be subject to the same types of penalties. So we'll get into it a bit later, but this is very crucial in why this work is so important.
Yeah, and we see new drug policy coming up all the time. There were drug-induced homicide bills that were introduced to the state legislature. So drug-induced homicide bills are where, let's say I bought some drugs from Jolie and I overdosed and passed away. Jolie could be charged with murder for my passing for selling me drugs that caused me to overdose. So like I said, we just want to talk about these things to kind of teach you how to look at drug policy through a critical lens about who does this benefit and who does this harm.
Neat. And so back to substances and materials. These are some pictures about what some of the things look like. So in the top left, crystal meth, right? It crystallizes. And so one of the terms is glass. It can look like that too. But that's the bubble pipe up there and what those look like. Just down below that, that's what a straight shooter looks like for smoking crack. And then cocaine's on the right of that. In the top right is a picture of some black tar heroin. Next to that is an example of sterile and unused injection supplies that would be given at a safe consumption space. I forget exactly where this picture is from. But it's an example of the gear or works that folks would use to inject. And then below that are the fentanyl and blues. So bottom right is Fetty powder. The pills, the picture of the pills are the blues that we see up top. That top picture are pharmaceutical perk 30s, and below that are counterfeit ones. Like the differences are so minor, and there are so many in circulation and presses that it can be hard to tell. So just some visual examples of what some of this stuff may look like if you happen to come across it in your day-to-day.
Yeah, so harm reduction in practice. Like we've said, harm reduction focuses on meeting people where they're at and encourages any small positive change. That change could be using a sterile syringe each time you inject, rotating injection sites so that you give your veins some time to rest and recuperate, smoking instead of injecting if it's possible and when possible. So something that we did see when fentanyl had a larger presence in Denver was that people were opting to smoke instead of inject more frequently, which is harm reduction because it's a small positive change for your body that, when you're not injecting, that's one less time that you're breaking your skin. That's one less time you're at risk for an infection. Using a mouthpiece when you're sharing a pipe with other people. So sharing smoking supplies, sometimes you can transmit things like hepatitis C to other people. So let's say Jolie and I are hanging out, we're smoking some stimulants like crack. Sometimes when you smoke stimulants, your lips get really dry, your mouth gets really dry, and so your lips will crack and bleed. So if I'm smoking and I have hep C and my lip starts to bleed and gets on the mouthpiece, and then I give it to Jolie and the same thing happens, I just spread hep C to Jolie. So using a personal mouthpiece that you can attach to your smoking device is really helpful in decreasing the transmittance of bloodborne pathogens. Also, just another fun fact, things like meth mouth are a total myth. It's not that people are smoking meth or stimulants that is causing them to lose their teeth. What's happening, like I said, sometimes when you smoke stimulants, your mouth gets really dry. And when your mouth gets dry, there's a buildup of bad bacteria. And so if you couple the buildup of bad bacteria with lack of access to appropriate dental hygiene, that's where you're seeing dental issues come out. Back to harm reduction in practice, using an alcohol pad before injecting. Alcohol pads are a great way to help reduce risk of getting any kind of infection when you're injecting. It cleans the skin. You give one swipe in one direction, saves thousands of dollars in taxpayer money at the ER for things like soft skin tissue infections, and they cost less than a penny. Not sharing snorting devices. Similarly to smoking, you can give hep C through snorting devices. So, you're snorting, one of your blood vessels in your nose blows, and you don't know it, and it gets a little bit of blood on the straw or whatever you're using to snort, and then you give it to somebody else, and the same thing happens. You can give someone hep C. So, a lot of harm reduction organizations will give out like safer snorting packs, safer smoking packs that have your own personal mouthpieces or straws so that if you're sharing with other people, everyone can have their own. Testing your drugs is harm reduction. We want to give people who are using drugs the autonomy and power to know what is in their drugs. So drug checking is one of the most effective things that we can do to keep people who use drugs safe. Chewing gum after smoking a stimulant. So chewing gum will produce saliva in your mouth, so that can help get rid of some of the bad bacteria that's building up while you're smoking stimulants. Doing tester shots or using less initially. You can always do more, you can't do less. Not using alone if possible, so that helps to curb overdose deaths. If you can use with somebody around, then there's someone there that can recognize and respond to an overdose if that happens. It's not always possible for someone to use alone. Sometimes you have to use by yourself. So that's why we put the if possible, using with someone around is preferable. Carrying Narcan is harm reduction or naloxone. And then using sterile water when you're prepping your drugs. Sterile water is really important, like Jolie mentioned, when it comes to actually prepping your drugs and using them. When you're injecting, you have to make something as blood-like as possible. If you don't have access to sterile water, you're going to use whatever you do have access to. That could be your Gatorade, your puddle water, toilet water, whatever you can get your hands on. So sterile water is obviously the best option when it comes to making something as blood-like as possible.
I also just want to shout out Josh in the chat for clearing that up. That is absolutely right. So the question was asked if perk 30s are fentanyl, and it was said yes, but Josh cleared up that perk 30s are oxycodone, and the fake ones that are Fetty blues are the only ones with fentanyl. Real perk 30s are oxycodone.
Yeah.
But this is an example of how we keep each other safe, because we are, how we keep each other safe because we're giving each other information. Also, yes, straws are harm reduction. It's not using dollar bills, that's right, breakdown of bacteria. But again, that also can help prevent Hep C. The blood vessels in your nose are super fragile and can be broken very easily. So if you have a straw and it's way up there, especially since cocaine is very numbing and you can't feel it, if you bleed on that straw and then give it to someone else and they put it in their nose and that bleeds, you can transmit that way. So it's harm reduction, yes, because you're not using a dollar bill, which could have more bacteria on it, and you're not transmitting any sort of blood-to-blood contact or making any sort of blood-to-blood contact.
Any other questions before we go forward?
Okay, cool.
So yeah, we're going to talk about overdose types and risk factors. So first, we're going to talk about opioid overdoses. So that would be heroin, fentanyl, any kind of opioid. So what does it look like? There's a loss of change in color in your face or nail bed. So there might be blue or purple. There's very slow to no breathing at all. That's a really big one that you want to kind of hone in on. If they're very, very slow breathing, it's shallow, or there's no breathing at all. The unresponsiveness as well. They might also have some gurgling noises going on. It's called the death rattle. Kind of sounds like a snoring or gurgling or it's like I said, a rattle that you can kind of hear. So some things that put you at risk for an overdose are mixing substances. So if you're using opioids and then you have other depressants on top of that, like benzos, tranquilizers, or alcohol, that can put you at risk for an overdose. Or putting stimulants in, that sends your body a lot of different messages that slow down and speed up all at the same time. Periods of abstinence, so if they were in jail, they were in treatment or in recovery, went to detox, have been using MAT services, things like that, can put you at risk for an overdose. Changes in the dealer or quality of your product, that puts you at risk for an overdose. When Colorado was almost exclusively black tar heroin, the purity ranged from like 2 to 20%, which is a really big difference. So if you're going from something at the lower end and bopping up to something at the higher end, you're at risk for an overdose. Changes in your health can put you at risk for an overdose. So you have to kind of be in tune with your body a little bit. And then there's the risks of respiratory depression, which is stopped breathing and death. And we're going to teach you also how to respond to an overdose, an opioid overdose. And then there's a stimulant overdose, which is also called overamping. And it presents a little bit differently. Well, not a little bit, a lot differently, a lot differently than an opioid overdose. So those signs and symptoms can look like red, hot skin, racing pulse, jerking or erratic limbs, severe psychological distress like confusion, paranoia, anxiety, They're in and out of consciousness. Risk factors, again, for overamping could be mixing substances, doing lots of stimulants together. Periods of abstinence, again, changes in supply. The risks for stimulant overdose are heart attack or cardiac arrest, stroke, seizure, overheating, psychosis, and then additionally a severe psychological episode of prolonged indefinite duration. So the best thing to do for somebody who is overamping is to put them in a very calm, cool environment. You can get a washcloth that's cool and put it on the back of their neck, anything to kind of calm them down so that their heart rate can slow down a little bit and they're not so, worked up. Anything to cool the skin down, and just make it as calm as possible for them and give them time. They need time to kind of come down from it. And then reversing an opioid overdose. So the first thing that you want to do if you walk up on someone or you're with someone and you think they might be overdosing, call out to them first. Hey, how's it going? Are you okay? If they're not responding to you, then you want to go ahead and do a sternum rub. If you've run through that checklist of things of like what an overdose looks like, they're unresponsive and there's no breathing, then you want to go ahead and do that sternum rub. So a sternum rub is where you take this part of your knuckle and you dig it into the sternum right here. It doesn't cause any damage, but it really fucking hurts. So if they're not overdosing, they're going to wake up from whatever sleep they were in. So if you do your sternum rub and they're not responding, then you want to go ahead and say it's an overdose. You can call 911 or tell someone else to call 911. In Colorado, we have the Good Samaritan law, so you and the person overdosing don't get in trouble for possession. That's mostly for like people who use drugs, so that they don't have a fear of calling 911 when they actually need help. Because what you see often in other states that don't have Good Samaritan laws is that people refrain from calling 911 when they need help with overdoses because they're afraid they're going to get penalized for possession. Now, this does not count if somebody has warrants, so that's, a little caveat to it. But call 911, you can say, this is where I'm at. You want to tell them where you are and that somebody is overdosing or just not breathing. You don't even have to say that they're overdosing. You can just say, this is where I'm at and somebody's unresponsive. And if it's just you, you say that twice, this is where I'm at, someone's unresponsive, and then you put the phone down because you've got other stuff to handle. And then you want to go ahead and administer your naloxone. Narcan is just a brand name of naloxone. It's the nasal spray. You can see different pictures of different types of naloxone in the corner. So the very top corner, the top left corner, no, right corner. Oh my God, that's embarrassing. The top right corner is injectable naloxone. That was the first type of naloxone that was readily available for people. So it goes straight into an arm or a leg. Y'all will probably not be getting injectable naloxone. If I had to guess what kind of Narcan you'd be getting, it's the Narcan nasal spray, which you can see in the middle picture. And it just goes up the nose and you squirt it. You press the little button. You can kind of see in the corner of the picture that it's like red, maroonish color, pinky, like pink. You'd press it up into the little atomizer and it'll spray into the nostrils. Aside from just the way that it's given, the biggest difference between injectable naloxone and Narcan nasal spray is the dosage. So injectable naloxone is typically 0.4 milligrams, and then Narcan nasal spray is 4 milligrams, so 10 times stronger. And that's just because whenever you're working with mucous membranes in the nose, it can sometimes take a little bit longer to absorb, so it needs to be a little bit stronger. So you want to give one dose at first whenever you're doing this, and then wait 2 to 3 minutes before you give another dose. That's just so that you're not inundating their body with a bunch of Narcan, because what's happening in an overdose is the opioids are sitting on the opioid receptors in somebody's brain, and it's causing them to not get any oxygen to their brain. Their heart is still pumping typically, and they're getting blood, but they're just not getting any oxygen. So naloxone goes in and knocks the opioids off the opioid receptors so that oxygen can get to the brain again. And so the nasal spray can just sometimes take a little bit longer to get up in there. And so you want to wait 2 to 3 minutes before you give another dose, because if you give somebody a bunch of Narcan back to back to back, really in a really short window of time, and they didn't necessarily need all of it, they're going to wake up and they're going to be really, really dope sick, and then they're going to want to go use again, and they could overdose again. And naloxone is only temporary, so once it wears off, they can overdose again. But if you're at that 2 to 3 minute mark and you've already given a dose, you can go ahead and give another dose if you're really freaking out. But we just don't want you to give like 6 doses in 1 minute because you're giving them entirely too much Narcan. And so you just want to kind of wait. And then after you give the first dose of naloxone, you want to start doing rescue breathing. So you're going to take their head and kind of tilt it a little bit, make sure their airways are clear, pinch their nose, seal your mouth around their mouth and breathe. It's just like you're giving, mouth to mouth. That's what you're doing. And you're going to breathe every 5 seconds. You don't need to do chest compressions in this scenario if their heart is still beating. Chest compressions can actually mess up the rhythm of their heart. So you want to focus on just getting oxygen to them. And then if needed, you can place the individual in the recovery position once they're back. So kind of like on their side, that way in case they start to vomit, they don't choke on it. And if you're with someone and you didn't call 911 for whatever reason, just make sure that somebody can hang out with this individual who just overdosed for a little bit. Because like I said, naloxone is only temporary and can wear off, and they can overdose again once it wears off. Cool.
Neat. And just a little bit to when assessing for responsiveness, in terms of breathing, it can be very slow. I think Alexis mentioned like the rattle, the gurgle, the snore. One of the bigger things too, if it's hard to tell, if you can see a steady up and then a down of their diaphragm or their shoulders, but they're steady up and steady down, that's a good sign that they're breathing. You still want to check for responsiveness to be sure they're okay. But the one physical thing too, if you see an inhale that's a little jerky, but you don't see that exhale, then that's not a breath. But I just wanted to go ahead and say that. I also want to say that where you will be staffed and working, there should be Narcan like available on site, and there should be an overdose response protocol. Obviously, only do what you're comfortable with. There will also be PPE available to you, whether it be like a mouth guard when you do mouth to mouth, so you don't have to make physical contact, gloves, etc. And we'll get into some of the myth busting around that, so it's not a big scary thing, but also just if you're the person who calls 911, if you're the one who initiates that response, that is okay. While this is information to know what to do in this scenario, if there's other people around, you don't have to be the one to do everything. Lean on people around you and give clear direction, knowing where you're comfortable and where you're able, right, in these scenarios is going to make all the difference. And that'll be the biggest help. So even if you just say, hey, this is happening, here's Narcan, and other people take care of it, you initiated and helped that response and saved a life. So just keep that in mind. No shame if you're like, I cannot do this to this person. That's fine.
Yeah, it is an invasive process to go through, and also like Jolie and I have done lots of reversals. It never gets easier to do. The impact of it never wears off on you, so just know that whatever you can do in the moment is enough, and it's okay to not be able to do everything, like Jolie said.
And then take care of yourself after.
Yes,
take the day if you can. Should be offered, whatever it comes with, because it is intense.
Yeah, very intense. Any questions about overdoses and responding to them? Yeah, David.
Yeah, I have heard that injectable naloxone works a little bit better against tranq dope than regular naloxone. Is that true?
So when it comes
or like the nasal spray?
Yeah, when it comes to other variants of opioids and other compounds that are in there, it's not necessarily about which one is better. It's about how fast you can get it to them. Any Narcan, any naloxone is great naloxone, and you want to use it. Even if it's expired, if that's all that you had, you would want to use that. So injectable naloxone, anecdotally, works faster because it absorbs quicker. But if all you have is Narcan nasal spray, it's going to do the job just fine.
It's also worth noting that it also depends on what is being used as a sedative, right? Because if naloxone only works on opiates, and so if there's something else that's a benzodiazepine, right, like a Xanax or an Ativan or something in the system that is causing that sedative effect, you might reverse the overdose. but they might not be responsive again or come out of it, but they might start breathing again, right? Because naloxone doesn't work on anything except for opioids.
Which is why it does get really tricky, like with the new like wave of trink dope with having xylazine, because xylazine does not respond to naloxone because it is not an opioid. So Jolie is entirely right. Like it really depends on what you've got going on, and like that's why mixing substances can be really dangerous. It all goes back to like all of the things that we've already talked about, like drug checking, which is why I said drug checking is one of the best tools that we have in terms of like people who use drugs and harm reduction, because you can know exactly what's in your drug and make informed choices going forward.
It's also worth noting that naloxone has no other adverse effect if someone is not experiencing an overdose. So if in any case, if you just give it, but that doesn't end up being the reason why someone's unresponsive, that's okay. Most first responders do this anyway. And we'll get into this a little bit in the myth busting portion, which is coming up soon. But like some folks think that if some analogs are so strong of fentanyl that like naloxone doesn't work. It does. It's just quantity. So that's a lot of info. Does that answer your question?
Yeah, it does. Thank you so much. Our site has both injectable and nasal, so.
Yeah, intramuscular is going to absorb quicker, but again, the dosage is higher. It's just, again, it's quickness on getting naloxone to them at all.
And I would say also like what you're most comfortable with in the situation too. If you're not comfortable with injectable naloxone and like having to inject someone's muscle with something, use the nasal spray. They're both going to work just fine.
Also, whatever your city can provide for you all to have this response, and also what the city kind of, or what your organization allows you to, right? So us at the city, we are not given guidance to use injectable naloxone in case we're not trained medical professionals, but everyone can use the nasal naloxone, right? And typically from the bulk fund is what we receive. But other organizations may be different. So checking in with whoever you're employed with to see what the guidance is there. Any other questions before we continue? We have about 10 minutes. Neat. So myth busting. So there's a lot of different myths around fentanyl. And so we'll go over some of these. The biggest myth busting the biggest myth that I like to talk about is overdosing by touching fentanyl. This cannot happen. Even in a liquid form, like it cannot enter your bloodstream through your skin. There's an instance that at the Denver Fentanyl Summit in 2022, there's an instance in which a pharmacist with cuts on his hands spills a bottle of liquefied fentanyl all over his hands and nothing happens. This was medical grade fentanyl. It also was an entire bottle. So some people say there's analogs and all of this and stuff we don't know that's being manufactured. And also like, it's just not a bioavailable like route of administration. It needs to be in an active form in order for it to have an effect on the body. And so we've heard a lot, there's a lot of sensationalizing in news and media about police experiencing overdoses, first responders, et cetera. A lot of the symptoms described with that are more akin to a panic attack than an actual overdose. I won't go into nocebo effect, but check that out. It's similar to Vis-a-Vago when you see blood. Right? Nothing's actually wrong, but you're getting nauseous and something is going on because of like a fear response or something else. It's similar. But folks are not overdosing by touching fentanyl. Again, that said, like whatever PPE makes you feel safe, if you decide to respond to an overdose, please use. That said, like if you respond to an overdose without any PPE, nothing bad is going to happen to you. It's just to mitigate other types of exposure. If we could overdose by just touching fentanyl, so many other people would be dead. So many first responders would be dead. Like it wouldn't be a couple or a few sensationalized things in the media. It would be a very pressing, oh my God, this is even bigger than the actual influx of fentanyl causing fatal overdoses itself, right? We'd want to know. People we work with who use fentanyl would all be dead. Like there are so many instances in which so many more people at an exorbitant rate would not be here anymore. Would it be for this? So we'd want to know if you could, but you can't. So I just really want to drive that in. Because that's one of the very big ones that people then make scared to help someone who could eventually experience a fatal overdose, right? If someone has more fear around that, then they won't respond to an overdose when they would be fine doing so. The other one I really want to touch on, maybe a couple others, just because we don't have a ton of time. No, again, like I mentioned before, naloxone does work against a fentanyl overdose. I have heard many times, oh, it's too bad it doesn't work on fentanyl. It does. If it's a potent opioid, it just means you need more Narcan. I facilitated a response with a couple of coworkers back in Massachusetts where it took at least 7 doses of Narcan to get someone to come to again. And the paramedic response, EMT response, was over 20 minutes. So it just was a long time. It took a lot of Narcan, but he was good. He was okay, right? So yeah, and the other one is, for the most part, drug dealers aren't maliciously contaminating drug supply with fentanyl. There are instances of sort of mixing or contamination. Again, we don't know exactly where that happens. For the most part, folks who deal or distribute are also looking out for themselves and their community. A lot of folks, of those folks, like will get unused or sterile syringes or other works or fentanyl test strips or Narcan. They'll try to give a heads up to their people. Hey, this batch is stronger, or whatever XYZ thing. They're doing their best to look out because, right, it's their community. It's also part of their income, right? There's interest there on both sides. But mostly dealers are community members, and so they're not trying to maliciously contaminate, hook, or inadvertently cause a fatal overdose to someone, or purposely, right, cause a fatal overdose to someone. So just things to keep in mind.
And then we wanted to briefly touch on recovery pathways. So although harm reduction does not necessitate moving towards recovery, the following are types of pathways of recovery that people can pursue if recovery is their goal. And remember, harm reduction is about meeting people where they're at, and that people who use drugs are the agents of their own change and autonomy over their body and what they want to do. So the first one is medication-assisted treatment, also called MAT. So that would include methadone, Suboxone, Vivitrol, naltrexone. Methadone and Suboxone are specifically for opioids. Vivitrol is for alcohol and opioids. So rehab could be long-term inpatient treatment where you'd stay for an extended period of time in a facility that is specifically aimed at treating substance use disorders. That could include an initial detox or stabilization time. It could not. Rehab can include include groups, 12-step program formats, therapy, etc. And then there's intensive outpatient treatment, which is usually used in conjunction with MAT services. That could include therapy, groups, classes, etc., but it is not part of a long-term stay in a residential facility. Some barriers to people entering into recovery could be cost, insurance coverage, detox bed availability, lack of access to methamphetamine treatment. So there is no FDA-approved drug like methadone or Suboxone that is aimed at specifically addressing substance use disorders for people who use methamphetamine or other stimulants. They have them in other countries. We just don't have them here. Something that people will use or prescribe often is Wellbutrin for people who use methamphetamine because it's hitting the same receptors in your brain that meth is hitting. So it helps to kind of, keep the cravings and curb those a little bit for folks. And then IDs, having an ID is a barrier to entering into recovery for a lot of people. At most MAT programs, you have to show some kind of ID in order to access the service. So just some barriers for folks. And then that's it. Does anyone have any questions? Oh, how can we download these slides?
This meeting has been recorded. So we can always refer out to that. And then the people who organized this have the slides, and so those will be able to be sent out to you for reference as well as access to the links inside the presentation for more information.